So it's now my great pleasure and honor to turn the presentation over to Dr. Geoffrey Knight. Thank you, Jeff, for joining us.
Yes, thanks, Phil. All right. So now I can start again. Well, apologies, everyone, and thanks so much for your patience. Anyway, so as I was saying, the dental caries to me has been something that I've traveled through the path of my career. And one of the things I've really understood, because we know that we treat periodontal disease as an infectious disease, but dental caries is something that is sort of, I've always thought I could not come to terms with the fact that dental caries was the only sort of, or the Dentine Pulp Complex was the only tissue in the human body that didn't have a frontline defense against bacterial invasion. And it seemed to me that we just removed the caries and put a restoration in. And as I sort of, again, my career has been such that sort of I pursued this through a PhD at one stage, and finally come up with the understanding that the dental caries is an ongoing inflammatory response of the Dentine Pulp Complex. So let's look at the anatomy of a carious lesion. So on the first thing, of course, is the enamel. You've got this as a demineralized caries dentine. The caries go through the enamel in a process dependent mainly on changes in pH of the outer environment. But then below that, you've got the necrotic or infected dentine, and this is basically it's like gangrene. It can only be remineralized as dental scar tissue, and it plays no active role in caries control. Improving enamel's caries resistance. Here we have a situation where on the left-hand screen, you've got that subsurface demineralization. The enamel's the tooth's been in a chemostat for a couple of weeks, and you see there that this carbonate apatite has been actually slightly dissolved, and that's a demineralization of 5.5. So a chemostat is basically a sort of a device that actually generates caries on a tooth. Now the right hand slide, okay, that was treated with silver fluoride and potassium iodide. Now you see there what I said was pre-etched for 15 seconds, and there's been no subsurface loss. If I just painted silver fluoride on that tooth, that would look exactly the same as it did on the left hand slide, because the fact is that the actual silver fluoride hadn't had a chance to enter the tooth. Now let me demonstrate. Right, so let's look at this slide. So the control was, I got some silver diamine fluoride and painted it on normal dentine. It wasn't demineralized, it's normal dentine, and put the chemostat for 3 weeks, I think. Anyhow, you can see there that the optical density was level of 1.6. That's sort of none the better, and you can see there that that's the standard variation. Now, I've got a specimen. So the silver diamine treated potassium iodide fluoride has a limited effect on the bacterial viability. Now you've got the demineralized dentine control. So all that was happening in these just where they were demineralized, and then after that they were then sort of subject to and this is non-vital dentine, by the way. They were subject to the chemostat. Now look at that. There's something in the non-mineralized dentine that still reduces the bacterial viability. So there's things that even though it's dead and it can't do anything, there's still something in there which is stopping the bacteria from coming out the other side and reaching full viability. And to me, this was just I thought it was a mistake in the data, but I went over and over again, and it kept coming through. Also, quite a wide standard deviation. So that also says that various teeth actually have different resistance, or various dentine specimens have different resistance. Now, this is a slide of my friend Graham Milicic, and this is showing a carious dentine which has been etched for 15 seconds. So that the mineral's been dissolved out of the collagen matrix, but to see the collagen matrix there is still patent. So you've got this sort of layer this level of sort of demineralized collagen, carious collagen, that's still collagen over the entire surface of the tooth. And what's happened here is that the silver iodide is able to form stable protein complexes with that exposed collagen, and therefore it's a much more stable situation than it was if you just painted the silver fluoropotassium iodide on the surface. How is the best way to restore a carious lesion? So this is a schematic diagram. You've got infected dentine, affected dentine, and sound dentine, and again, all this is sort of carbonated apatite. There's no fluorapatite here at all, or hydroxyapatite. It's all carbonated apatite, and that's something that you should sort of get your head around when doing it. So we're going to do a restoration here. We're going to do a restoration with composite resin. So the question is, what's the bond strength of composite resin to carious dentine? Has anyone ever seen a paper on that? I think there have been a couple of papers, but I think there's been a lot of papers on this, but the thing is they haven't bothered publishing them because the results are pretty ordinary. So therefore, if you're doing a composite resin restoration, you've got to take away all the infected dentine and all the affected dentine, and to make sure you've got a sound restorative base, you've got to take a little bit of sound dentine away. So it's a fairly substantial cavity preparation to do that, restoring that with straight composite resin. And you can see this is a slide of Ivan Muir's, that very old slide, but it shows that once you've actually sort of prep a tooth for a crown, and then sort of this is teeth that were being used for extracted for orthodontic reasons, you can see that ON is the nuclei of the Dentine Pulp Complex being sucked up into the dentinal tube because of the trauma of crown preparation. So it's a fairly aggressive thing to do to a tooth. Okay, so this is what for a small occlusal cavity, that's what it looks like. And I'm using visual contact as I suppose my means of actually determining where things are. And it's usually the colour of the dentine. Not always right, but you've got a situation there where you've got the infected dentine. I've left there about 5 millimeters thick, just over the deep part of the cavity of the pulp. Then I've got the affected dentine ring around there, and you see there's my peripheral note to actually sort of as my insurance policy to make sure that we're not going to get any leakage.